hypertension, and she was managed with acetazolamide, and her ATT were continued. At that time, in CMH Multan, he had a normal brain MRI and CSF analysis was also performed, and that was, and both were not in favor of any meningitis or TBM. So she continued with her ATT, and in October 2019, her ATT was stopped by her treating physician after 9 months of treatment. And that time, when she was stopped with her ATT, she was asymptomatic, and her cervical lymphadenopathy, it was completely resolved. Later on, few days after stopping the ATT, she again developed cervical lymphadenopathy, and then repeat FNAC performed, and this time her MTB gene spurt was positive with rifaximin resistance. Although AFP smear was also positive, but MTB culture remained negative. So line probe assays were performed at National TB Reference Lab Islamabad, and that report also confirmed rifampicin resistance. But the organism was still sensitive to INH, quinolones, and second-line injectables. So, 2020, he again started with antituberculous therapy with 6 drugs. Because of cervical participants, या mic जो है उसे म्यूट कर लें ताकि अन जो है necessary sound हम. So she was started with 6 drugs in the form of levofloxacin, clofazimine, bedaquiline, cyclosporine, and ovulate. And in the meanwhile, her headache got worsened, and on examination there was high CSF pressure. So this time our LP shunt was placed in January 2020. And soon after the placement of this shunt, she developed shunt-related meningitis and treated with ceftriaxone and vancomycin for 14 days. And she continued with her 6 drugs HTT. And during that treatment, her cervical lymph nodes, they continued to drain for the next few months. And so one times lymph node aspiration was repeated, and the result was same positive MTB gene expert with rifampicin resistance. But culture this time also remained negative. Towards the end of 2020, she again had bacterial meningitis and treated with antibiotics, but shunt was retained, and she continued with her ATT with good compliance, and there was the complete resolution of cervical lymph nodes swelling. And but in November 20, she again third time developed shunt related meningitis, and her LP shunt was removed and it was replaced with a programmable shunt. And during that period, she also developed one episode of fungal meningitis with candida growth and treated with fluconazole. So in January 21, the patient completed 18 months of this modified ATT regime, and in the next few months, she remained afebrile with a few shunt-related issues and headache on and off. But if we summarize the sequence of events up till now, so we had a young girl with no comorbids except this idiopathic intracranial hypertension. She had cervical lymphadenopathy, and only gene expert was positive with fully sensitive, and there was no rifampicin resistance initially, and she received ATT excluding RIF for 9 months. And soon after stopping this 9-month regime, she relapsed with cervical lymphadenopathy, and then this time MTB gene expert was positive with RIF resistance. So she was treated with an 18 months course of 6 drugs initially, and then 1 drug excluded, and with 5 drugs. But currently in July 2022, she visited SKM ID clinic and with complaints of headache that was present from last 2 months, and bilateral lower limb weakness from last 1 month. Headache was generalized all over the head, mild to moderate in intensity, radiating to the back of the neck more in the early morning with occasional episodes of vomiting. And bilateral lower limb weakness was present from almost 1 month. That was gradual in onset, developing over the period of few days. Initially, she had problem in walking in the form of ataxia and difficulty in walk. But in the next few days, the weakness worsened and she became bedbound. And this bilateral lower limb weakness was associated with urinary incontinence, numbness of the lower of the body up to the epigastric region, and pain over the back, especially in the thoracic region. And this weakness was so severe that she was unable to walk and she was bedbound from almost last 1 month. But with these complaints of headache and bilateral lower limb weakness, there was no history of fever, cough, expectoration, diarrhea, pain abdomen in the last 2 months. She also denied any history of seizures, transient loss of vision, or any focal neurological deficit apart from this bilateral lower limb weakness. She also denied any history of joint pains, rash over the face, or photosensitivity, or any history of trauma to the spine preceding to these events, and or any history of lumps or bumps over the body. And since her systemic inquiry was also unremarkable for any history of confusion, any type of rash over the body, or in the over the body, or in oral cavity, or any type of genital lesions. She was an unmarried young female with no sexual contact history, no history of IV drug abuse, or any history of tattoos or repeated transfusions. So, based on these complaints of headache from last 2 months and bilateral lower limb weakness, and then what I have mentioned, what can be the diagnostic possibilities in this patient? आवाज क्लियर नहीं आ रही जो भी
we can ask from fellows.
Can you give a brief summary of the case, like a brief three-liner?
If we summarize, so a young girl with just 18-year-old female with no comorbids except this idiopathic intracranial hypertension. She developed cervical lymphadenopathy, and she was started with the first line ATT based on cervical lymphadenopathy and just positive PPD. And she took for 3 days, and she developed some rash, and so it was stopped, and FNAC of that lymph node were performed that revealed only genes got positive with no rifampicin resistant. She was started ATT, but a modified ATT excluding the rifampicin. That she took for 9 months and then stopped. At the stoppage, at the time of stoppage, she was afebrile, and there was complete resolution of the cervical lymphadenopathy. But soon after this stoppage, she developed again cervical lymphadenopathy. And this time when labs was done and FNAC was done, there was positive gene expert with rifampicin resistant. AFE was positive, but there was no growth on culture. And she was with 6 drugs, and that she completed 18 months of 6 drugs. And in the meanwhile, she had some shunt-related issues due to her idiopathic intracranial hypertension. But she, at the end of treatment, she was good. She was afebrile, and now she had presented after stopping the almost 9 months or 10 months of ATD. She has presented with headache from last 2 months and bilateral lower limb weakness from last 1 month.
Okay, thank you. Fellows.
So we have
My name is Dr. Shakil, and I'm fellow at Aga Khan Hospital. So for me, HIV was done and not done at this time of.
It was negative. She was because she had tuberculosis. She tested for HIV twice, thrice, and every time she was negative.
One DD will be post disease or recurrence of the disease, disseminated TB, and it may be some paraneoplastic syndrome.
Because, but she had no known history of any malignancy. So in the absence of malignancy, we cannot think of some paraneoplastic syndrome.
we have some answers from the chat, and Dr. Danish is saying that amyloidosis and disseminated tuberculosis.
Disseminated tuberculosis can be a possibility, but amyloidosis usually presents with peripheral neuropathy and involvement of the heart and other issues. But it may be the It may be the possibility because it may involve the spinal cord and can cause a compressive myelopathy as well. But can other possibility?
CNS lymphoma.
This CNS lymphoma may be a possibility, but considering her HIV status, that's negative, so it may be a possibility. But in the setting of HIV positive status, it is more likely a possibility. But it may be we can consider this.
Recurrence of lymphadenopathy after starting at 2-3 times can be lymphoma type disease, lymphoma.
But her lymph node specimens, they were examined thrice, and every time there was no evidence of any malignant cells or the malignancy.
Sorry, but can you?
It may be simply due to the because it's quite common that a patient with the tuberculous lymphadenitis, and we start him with ATT, and there may be infection in the lymph nodes in the form of swelling of the lymph nodes, and sometimes with sinus formation, discharge. So it's not unusual, something unusual in the setting of tuberculous lymphadenitis.
This time when she came with lower limb weakness, was there any associated lymphadenopathy or any other systemic
There was no lymph node palpable or even on ultrasound in any other region of the body.
Another possibility could be iris.
But this time we had not started the AGD. She was stopped with AGD 9 months back, and currently she was not on AGD, or recently we had not started with AGD. Although it's quite common that in CNS tuberculosis, when we start treatment, the patient may develop IRS, and the risk of IRS is more CNS tuberculosis as compared to the other extrapulmonary form of tuberculosis. But this time we have not started any Sorry, I cannot listen to.
It was plastic or flaccid?
I will mention the details of the examinations later on. This time, at this moment, we are only talking about just the diagnostic possibilities based on history. Later on, we will see that what happens after examination. Syringomyelia, one skill, Dr. Shakil Rahman mentioned syringomyelia. It can be the possibility, syringomyelia can occur, but there is nothing in history to suggest that there is involvement of the upper limb or with loss of sensation or sensory dissociation or things like this. Okay, let's see what. So based on history, we can have some diagnostic possibilities that most like she may have tuberculosis, recurrence of or relapse of that tuberculosis in the form of tuberculous lymph spondylitis with compressive myelopathy. That can explain the involvement of the bilateral lower limb. And even she may have some less common type of CNS tuberculosis, so-called tuberculous spinal meningitis, in which there is involvement of the spinal cord as a part of tuberculosis. Or she may have some swell in the brain in parasagittal location, and that swell brain may be in the form of some meningioma or some even brain abscess or some other lesion, because any swell brain in parasagittal location can explain with this headache and as well as bilateral lower limb weakness. Even she may have this acute inflammatory demyelinating polyneuropathy, because this can explain this bilateral lower limb weakness, and we can explain the headache, although it's less common, less likely possibility, because to explain the headache, we have to consider some other possibility, like we can explain her headache with this history of idiopathic intracranial hypertension. And even this may be due to transverse myelitis. Transverse myelitis can be due to some autoimmune disorder. Even it has association with malignancies, or sometimes it's occurs after infection. Even after tuberculosis, someone may have this transverse myelitis. So for this headache that she had from last 2 months and lower limb weakness, she got admitted in some hospital, and where her MRI brain and spinal cord was performed. She was treated with high dose pulses of corticosteroid, even plus IV immunoglobulins for 5 days. And again, she was started third time with anti-tuberculous drugs in the form of ethambutol, INH, PZA, ciprofloxacin, and amicus. Later on, they stopped ethambutol due to visual problem, and she had severe vomiting, so they also stopped PZA. And after receiving that treatment, she had some improvement in her weakness, and but headache and urinary contest remained the same. So when examining the patient, young lady lying on the stretcher, conscious, she was alert. Her GCS was 15/15. She was vitally stable with a temperature of 37.5 Celsius. Blood pressure was 120/70. Pulse was 87 beats per minute, and respiratory rate was 19%. She had mild pallor, but no jaundice, rubbing. She had scar at the left arm. Accessible lymph nodes, they were not palpable at that time, but she had some scar in the left interior cervical region, likely maybe due to old formation and discharge. Signs of irritation was negative. She had no abnormal movements, and there was no localized tenderness of her spine or any spinal deformity. She was gastralized, and on examination of the lower limb, there was no wasting or fasciculation. Power was 3/5 in both flexor and extensor of the lower limb bilaterally, and but in upper was 5/5. Bilateral plantar response was extensor. Deep tendon reflexes, including the knee and ankle jerk, they were braced in the lower limb bilaterally, while upper limb reflexes were normally elicitable. Pinprick sensation was reduced in the lower half of the body up to the epigastrium, while vibration and joint position senses were intact. Cranial nerves were intact. but she had some blurring of vision. She was complaining some blurring of vision. Examination of the fundus was also unremarkable, and on examination of the chest, there was normal vesicular breathing anteriorly as well as posteriorly with no added sounds. Pericardial auscultation was unremarkable, and abdomen was soft and tender with no visceral. So you have the examination findings, and what can be the diagnostic possibilities after this? If we summarize the examination findings, she had spastic paraplegia with bowel with bladder involvement, as well as she had a definite sensory level.
The problem is in the spinal cord because of sensory level. There is something wrong with the spinal cord.
Now, what can be the possibility? So the possibilities we made based on history. Out of those possibilities, no SOL brain is ruled out because in the involvement of the brain, there is no sensory levels. Because sensory level, a sharp sensory level is a feature of spinal cord involvement. Even this acute inflammatory demyelinating polyneuropathy is ruled out because she had upper neuron type of, but still we have the possibility of this tuberculous spondylitis with compressive myelopathy, or she had this tuberculous spinal meningitis, or she may have this transverse meningitis. So next, what we can do in labs so that we can get answers of this question and we can narrow our differential diagnosis.
What is remember tuberculous spinal meningitis?
Sorry, I cannot understand your question.
Tuberculous spinal meningitis. What does it mean?
आप क्या कह रहे हैं कि tuberculous spinal meningitis will be the possibility?
I want to ask that what does it mean that tuberculous spinal meningitis?
Okay, I will explain it later. It's a type of CNS tuberculosis, although it's a less common or rare type of CNS tuberculosis. But in this tuberculous spinal meningitis, there is the involvement of the spinal cord as a part of central nervous system involvement of in tuberculosis. So spinal cord meninges are involved, and even there is involvement of the spinal cord as well.
Okay.
This first possibility, tuberculous spondylitis with compressive myelopathy, we usually commonly see that we see many patients who had this tuberculous spondylitis, we call it the Port's disease, and they have involvement of the spine, and then as a part of the involvement of the spine, they have compressive myelopathy. But this tuberculous spinal meningitis is something different, in which there is involvement of the meninges around the spinal cord, and along with that, even there is involvement of the spinal cord itself as a part of the pathophysiology of tuberculosis. Okay, let's unreveal some more. First, MRI, especially of the thoracic spine. Anyone can appreciate these changes in that picture, especially with respect to the spinal cord? Actually, you can see that
सिग्नल जो आ रही है
आपकी आवाज कट कट के आ रही है. What is this? Okay, let's see the report. So on MRI brain and spinal cord, with contrast, she had what? She had diffuse abnormal nodular meningeal enhancement throughout the length of the spine. and there was an intradural extramedullary fluid collection seen anterior to the distal thoracic spine extending to the upper lumbar spine. And this was causing the distortion of the lower thoracic spine with compression of the abnormal, as well as she had some abnormal signals in the spinal cord as well. So this was the collection, and it was compressing the spinal cord, and at the same time she also had meningeal enhancement throughout the spinal cord. And surprisingly, there was no evidence of spondylodiscitis. And in brain imaging, she had basal meningitis and a small tuberculoma in the left parietal lobe as well. So actually, she had this spinal tuberculous meningitis. She had a relapse of tuberculosis, and that may be due to the use of these. Maybe the possibility that she had an episode of transverse myelitis as totally as a separate pathology, and they use the high dose steroid and IV immunoglobulins, and that triggered the reactivation of tuberculosis. Or there may be the possibility that she had simply relapse of tuberculosis in the form of this tuberculous spinal meningitis. So if we discuss the CNS tuberculosis, so most common manifestation of CNS tuberculosis are tuberculous meningitis, cerebral tuberculoma, tuberculous abscess, or even we commonly see tuberculous spondylitis with compressive myelopathy. But less common manifestations of CNS tuberculosis are spinal tuberculous meningitis, serous, in which there is involvement of the spinal cord and the meninges. And there is another variety that's called serous tuberculous meningitis, in which there is sign and symptoms are mild and there is spontaneous recovery. And in children's, there is an entity called tuberculous encephalopathy, in which the conscious level is affected more, and neurological deficit is more. So if we talk about the staging of tuberculous meningitis, so since long, British Medical Research Council TBM staging is used, and this staging is important because the stage at presentation has a strong association with prognosis. In stage one, the patients, they usually don't have specific neurological deficit, or they have non-specific mild sign symptoms, and their most importantly, their GCS is 15/15. But at stage 2, they have some alteration in the conscious level, but GCS is not less than 11, and they may have some focal neurological signs or involuntary movements. And stage 3 is an advanced disease in which there is dense neurological deficit, and the conscious level is severely altered, and GCS is less than 10, and it has a poor prognosis. So if we talk about the differential diagnosis of CNS tuberculosis, so actually CNS tuberculosis may be confused with partially treated bacterial meningitis, or it may be confused because CNS tuberculosis manifestations are non-specific, and they are even not, they are subacute or chronic. So it may be confused with brain abscess, fungal meningitis, even brucellosis, or even in the with some parasitic infections that involve the CNS, like toxoplasmosis or neurocystic cirrhosis, even with cryptococcal meningitis, CM, cytomegalovirus, encephalitis, or CNS lymphoma. These 3 possibilities are more common while the patient is HIV positive. And even CNS tuberculosis may be confused with meningeal metastasis, or with some autoimmune disorders like neurosarcoidosis or Paget disease. So how we will work up a patient with the suspected CNS tuberculosis? Because CNS tuberculosis or the TBM, tuberculous meningitis, it has non-specific signs and symptoms, So based on history and examination, in most of the cases, it's not possible to make a diagnosis. So in workup, we will get the baseline workups, as in most of the cases, we start with the baseline workup in the form of CBC, renal functions, liver functions. We will get the HIV status of the patient as well when we are considering this tuberculosis. And serum electrolytes, especially, we'll check for the sodium, because almost 45% patient with TBM, they have a low sodium hyponatremia, maybe due to syndrome of inappropriate LDH. So, and then we will proceed for spinal tap, because most of the patients with TBM, they have raised ICP, so there's obviously a risk of herniation. So if there's so we have to decide between low volume or high volume, because low volume spinal tap, it has decreased sensitivity for TBM diagnosis, and ideally it should be high volume spinal tap. But if there's a raised ICP and there is a risk of herniation, we can even proceed with low volume spinal tap, and we can test for the most common causes of meningitis, like bacterial meningitis, and we can rule out the possibility of bacterial meningitis. Obviously, when we will perform this spinal tap, we will measure the CSF pressure, as we do with our other possibilities. We will measure the CSF pressure, and in about 50% patient of TBM, CSF pressure is raised. And then after CSF pressure, we will do this physical inspection of the CSF. In TBM, CSF will be clear, or in some cases it will be mildly turbid, or even in some cases it may be hemorrhagic, because as we know that TBM involves the blood vessels in the subarachnoid space, and it may have hemorrhagic CSF as well. And then we will perform the routine chemical examination of the CSF, in which we will measure the glucose. That will be decreased, as with many other bacterial causes of meningitis. We will measure the proteins. Proteins are raised even, and then we will measure the cell counts. And cell counts will be increased with lymphocytosis. Lymphocytes will be the predominant cells, and then we will measure the ADA levels in the CSF. This adenosine deaminase levels in the CSF. It can be, although it's neither diagnostic, it's not such specific or sensitive, but it can aid, it can help us in the diagnosis, because there are two meta-analyses that has used this CSF ADA levels for the diagnosis of TBM, and they have found a significant sensitivity and specificity of this test. But this interferon gamma levels in the CSF, this has not been studied much in the diagnosis of TBM in CSF, although studies are available for this in pleural fluid, but studies are not available for this in CSF. We can perform MTB gene expert on CSF, and it has a sensitivity of about 60% with a specificity of 98%. And WHO recommends that we should perform ultra gene expert rather than simple gene expert on CSF. AFB stain, we can perform AFB stain on CSF, and it has sensitivity of about 10 to 30%. And we can then obviously perform the NTVD culture that has almost sensitivity of 45 to 70%. And in order to rule out the differential diagnosis, we can perform the fungal as well as bacterial cultures. And then there are two new tests that are not well validated and studied, but they are in the pipeline for the diagnosis of TBM. One is the one tube nested PCR with lateral flow strip test. This test is just like gene spurt or ultra gene spurt, but it has more sensitivity. It can even detect low levels of MTB DNA in CSF. And then there is another test, that is the dot immunobinding assay, and this test detects the anti-TB antibodies in the CSF. Then we can get help from the imaging in the form of chest X-ray, and even in the form of CT or MRI. We can find hydrocephalus or basal meningitis or intracranial tuberculosis or even calcification on this imaging. And sometimes we can find the evidence of spinal spondylitis with compressive myelopathy, and even we can find, like in our case, spinal meningitis. And CT angiogram is required only when someone with suspicion of TBM and he or she is also having this stroke, we can perform CT angiograms. Regarding the management of CNS tuberculosis, multi-drug anti-tubercular therapy is the mainstay of treatment. And if the patient is, and depending upon the results of this gene expert and the culture, we treat the patient with first line or the second line drugs. And in the management of TBM, with anti-tuberculous drugs, we also use the corticosteroids, because the corticosteroids, they have mortality benefits. We can use dexamethasone. Most commonly we use this dexamethasone, but in even children we can use this prednisone as well. And if in adults, there is also some role of aspirin in the management of tuberculous meningitis, because to prevent the risk of stroke. But this is not approved for even some studies are available, and they are just for adult patients. And obviously, because treatment is during the treatment for response as well as for complications, and neurosurgical input for the treatment of TBM complication is important, because sometimes there is hydrocephalus and we need some CSF diversion procedure to treat this hydrocephalus. And even sometimes there are tuberculomas and they are not responding to therapy, and we use this neurosurgery to remove those tuberculomas. So few things about the CNS penetration of the anti-tubercular drugs. All anti-tuberculous drugs we use, they don't have the same CNS penetration. There are certain drugs that have good CNS penetration, like fluoroquinolones, INH, isoniazid, cyclosporine, and PZA. They have a very good penetration. And then there are certain new drugs that have good efficacy for tuberculosis, but data is much few regarding their CNS penetration, and these group include bedaquiline, delamanid, and clofazimine. And then there are certain drugs which have poor CNS penetration, like ethambutol and this para-aminosalicylic acid, minoglycoside, and even this rifampicin. So normally in CNS tuberculosis, we don't find this involvement of the spinal cord. So I searched the literature regarding this involvement of the spinal cord in CNS tuberculosis, and I found that there was a Chinese study. It was a retrospective study in which they found that they retrospectively studied 114 patients in 2 hospitals of TBM, and they found that spinal cord involvement was there in about 19 patients. And so it was about 16 or 17% of the patients with TBM, they had this spinal cord involvement in the form of tumoritis. Then I found another case report series of 4 case reports in which patient with CNS tuberculosis, they have spinal cord involvement in the form of extensive transverse tumoritis. Even I found few case reports from Pakistan, like this one, even from Lahore, in which one patient with longitudinal extensive transverse myelitis had spinal cord involvement due to tuberculosis. And then a review by Gupta and colleagues, they also found that they actually reviewed multiple case reports published in English, and then they concluded that spinal cord involvement, although less common, but it may occur as a part of CNS tuberculosis, and it has poor prognosis. Similar was the result in this study that was conducted in Malaysia. They also found that spinal cord involvement may occur in CNS tuberculosis, and outcome is overall poor when there is involvement of the spinal cord. So if we summarize our case, that is spinal tuberculosis, although less common, but it's a serious complication of CNS tuberculosis, and it can have a presentation similar to transverse myelitis or acute inflammatory demyelinating polyneuropathy. And history, physical examination, CSF analysis, and neuroimaging, together these modalities, they can help to reach the correct diagnosis, and anti-tuberculous drugs with steroids and neurosurgical input are the mainstay of treatment. Although prognosis is poor in terms of mortality and morbidity. So this was all about today's case. Any questions?
Is there any specific pattern for the spinal tuberculosis? Just like in we say in birth disease that the disc is damaged and there is dirty pictures. So there is some specific picture for this CNS spinal tuberculosis which make us to think of spinal tuberculosis with the help of imaging.
As this type of CNS tuberculosis is less common, although some we can say that it's rare. So there are certain case reports on it, what I found on it research, and there are few studies, and in most of these studies, involvement of the spinal cord, there's no specific pattern, but and in most of these cases, they found what there's involvement of the meninges and spinal cord involvement, and even in some cases, there was the formation of serines in the spinal cord. And these clinically, all these cases.
Picture, the serines that made you think of spinal tuberculosis as the diagnosis.
Yes, and especially the involvement of meninges, like in our case, she had meningeal involvement with enhanced nodular enhancement and a small collection as well. So, and even we found this involvement of the basal meningitis, and so based on imaging, we can have some idea due to the, because even if you found tuberculoma, then we can have some idea that it may be due to tuberculosis.
One more question from the chat is, what is the clinical update on the patient and what ATT regimen is she is now?
Currently, she visited our clinic one times, and then we have a plan to repeat her CSF analysis and shift to her on a better WHO long-term regime of MDR. But later on, when I called the patient, and it was unfortunately she had developed worsening of her conscious level, and currently she is admitted in some ICU with poor GCS. So but we think that she should be on, as she has rifampicin resistant tuberculosis, so she should be on a MDR regime, or preferably, definitely she will be on longer regime, a longer WHO regime for MDR tuberculosis, based on the availability of drugs.
So other question is, RIF resistance thought to be MDR. What was the resistance pattern on LPA?
Well, as I have already mentioned that on LPA, there was rifampicin resistant, but actually the patient has a long record and there was only a single visit. And what information I was able to gather, that on LPA, she had rifampicin resistant, but her organism were sensitive to INH and fluoroquinolones and second-line injectables.
So was the paraspinal collection drained and sent for
Actually, neurosurgeon was consulted for this, and but it was planned to drain it, but due to the worsening of the patient condition, currently it was not possible. On family screening, she had no history of family history of tuberculosis, and she belonged to a upper middle class and living in a city, and there was no family history of tuberculosis.
So there are no more questions, so we can end the meeting.
Okay.
I want to add this is an index case, so family screening must be done if any children or this exposure to the because this is a resistance case. So the family or children are under 5 years and 5 years that we have children should be preventive medicine by the recent guidelines and to screen.
Okay. And this discussion as well.
Yes, okay. Thank you.
Okay, thank you everyone.